Good day, all, and welcome to the Teledyne Pulse podcast, your Rural Health Matters resource. Hear from your colleagues and industry experts on rural health issues and innovative care models that make a difference for rural hospitals, providers, and communities.
Hello and welcome to the Teledyne Pulse. Shane, before we get started, I need to apologize to our listeners a little bit. We didn't have a podcast last month because we were just a little busy.
Yeah, you know, the Rural Health Transformation Project is definitely caused a lot of activity, for really everybody across the country trying to better understand it and help how it can help rural hospitals transform their care delivery models.
Yep.
And so we've done a lot of work on that front and trying to touch base with as many key constituents as possible as part of that process. So a lot more to come on that for sure.
Yeah, for sure. We'll have to check in on that as things develop. So let's go ahead and get started. We're going to talk a little bit about transfer analysis, ROI, some pretty exciting things to kind of dig into and talk about how maybe some of our services can help improve some of this.
Yeah, Andy, I think the transfers are such a key piece of a lot of different things that really are. Transfers is something that's often overlooked in a lot of facilities, and as you mentioned, we do a lot of strategic planning sessions, specifically around digital health strategy and virtual care models, and really how those engagement sessions come together. It's really looking at what's your strategic plan look like, what's your community needs analysis look like, and then we go down this long trail of various questions, probing questions, kind of flushing out various challenges, issues, and needs. Maybe you knew you had,
or
didn't
maybe
know,
not,
or maybe you did know you had those, or maybe it's an issue, but perhaps you didn't understand the root cause or potential root cause, or that there's a solution that could help solve that you were unaware of. And so it's really meant to be a session to flush a lot of that out, but then design a solution or solutions around that. And then ultimately, what are we trying to accomplish with that? And based on the solution and then what we're trying to accomplish, can that solution actually do that?
Yep.
And then furthermore, what does that return on investment look like? And what's the value proposition by launching service X, Y, and Z into a facility? So, and there's a lot of different components to that. I won't get in the weeds on that, but those sessions are some of my favorite things to do. And they really are valuable, robust discussions with a lot of these executive teams across the country that we do those with. And one of the things we're going to talk about today is transfers, which is a key piece of the discussion in that process. And oftentimes it is one of the most light bulb moments, I would say, in a lot of these sessions for a lot of teams. And I would also, refer you back to the ROI discussion we had with Dr. Hollander here a while back. I believe that was episode 31.
That's correct.
So check that out. And that's a bit more broad scope from what we're going to talk about today, which is specifically transfers. But as you and I talked here the other day, we thought, gosh, what's the most one of the most provocative things you end up getting involved in these discussions, and transfers is one of those. And
transfers is definitely one of those.
So we thought we'd unpack that today.
Yeah,
Andy.
That sounds great.
And so, as I mentioned, this is part of the engagement process, but I think as you look at transfers, it's not that executive teams don't think about transfers; they do. But we really take it multiple steps further in examining transfers. And the reason we spend a lot of time examining these transfers is it's a captured audience, right? And one of the most powerful ROI metrics in the hospitals, if you go back to our last the webinar we just did, the Lunch and Learn, in the fireside chat with Chuck Nordyke out of Clarendon Regional, where he said, that they've doubled volumes across every single sector of their hospital.
Exactly.
Every sector has at a minimum doubled. And the only way you can do that is with people in the building. Now, I call it butts in the beds because that's really what you need. And so as you think about that, of course, you have your natural outmigration, you have your self-induced outmigration. We'll talk a little bit about that. But transfers is one that literally there are people in your door that are, for whatever reason, being transferred out.
Right.
And it's a key patient population we want to examine and figure out, can we make a difference on that front? And so there's a lot of different things that we would look at as part of that transfer process. And we'll go through some of those here in just a minute. But the nice thing is when we start these programs, we really try and lead a hospital down. What does an ROI proposition look like? If we launch these programs, how many patients do we really need to take care of to say break even?
Right.
Or what do we, based on the numbers, what do we think this is going to look like come year 1, 2, 3, 4?
Right.
And here's what we're projecting. And oh, by the way, if we just hit mark X, then we're going to break even on the project. Because again, you've heard me say this 1,000 times, we're not going to be a financial boat anchor for our institutions and our clients. And so, but the transfers is one that in most cases, the conversation starts with, it may or may not be the CEO in the room. I mean, the CEO's in the room, but he or she may not be the one reviewing the transfers. And so one of the questions I always ask, an early question in the engagement process is, do you have a transfer analysis process? And many of them, I should say 50% of them will say, yeah, we do. I look at transfers.
Yeah.
And so that, again, so I always have my 5 whys, right? So why, tell me about that. How do you go about doing that? And oftentimes it's a superficial process. I get a report from, the ED, once a month, and it lists all the transfers, and and then I sit down with the CMO and review the transfers. Or I might go to the provider or the medical staff and ask them, hey, we transferred out 50 patients last month. Here's the diagnoses. What, and oftentimes it's no, we're taking care of everything here we possibly can.
Everybody we can.
Safely can. Again, safety comes up, quality comes up, the what ifs, what if, and then boom, transfer. But it is a significant that if I'll tell you, the CEOs I've worked with to really get into the weeds on transfer analysis has opened up a lot of eyes in terms of, gosh, there's more to this than just the patient going down the road. And so as you look at it, and we do have a transfer analysis tool that we can send them, there's no cost to it. But we do go through that with them and evaluate all the different metrics. So we'll go through that with the audience today. And, I think as you look at, obviously it's a key captured patient population, but there's other factors that coincide beyond revenue with patient transfers. It's a major patient dissatisfier.
Yeah.
And as you look at that, and having been eons ago a paramedic and having to take these patients over the road and then working in the ERs and loading these patients up on the gurney going, why are we transferring this person? They don't need to go. They just don't. And by the way, I want to emphasize this. This is a significant key point here on transfer analysis in the tertiary centers. There are patients transferred every day that don't need to be transferred.
Every day.
That are hitting the tertiary centers. And so there's work to be done here still. I mean, we've prevented hundreds of, I don't know, maybe it's I know it's thousands of transfers for sure, including air transfers, but thousands of transfers we've prevented. And there's more to be done, and it can be done.
Well, you spoke about as a patient satisfier. So, the impact of a transfer on patient satisfaction probably isn't great. But if I've got a great patient satisfaction score, does that mean I'm keeping everybody?
Well, all the patient satisfaction score is measuring is the patients you're taking care of in the building.
That's true.
It's not measuring who you've transferred out.
The ones you're not taking care of.
It's just not. But we found in communities that we've did this type of analysis, and I won't bring up the name of the community, but in one example, their patient satisfaction scores were fantastic. But their numbers they were hemorrhaging patients out the door, patients, and via transfer. But there's another phenomenon that starts to develop when you transfer patients. Again, I want to emphasize this. Patients don't want to get thrown in the back. I mean, facetious when it comes to throwing. They're not throwing people in the back of the ambulance. Don't get me wrong. But people do not want to ride in the wagon to another community, regardless where that's at. Regardless of how much time, their families don't want to go there by and large. and it's a dissatisfier.
Well,
and
after a time, don't they start to self-transfer?
They do. They start to self-out-migrate, but it's a step before that, though, is the word spreads.
Yeah.
And especially the smaller the community, the quicker and more penetration the word has, right? And so as the word starts to expand, don't go to Hospital X, they're just going to transfer you anyway.
Right.
So if you got anything beyond a hangnail, go
just drive on down the road.
Yeah, keep on driving, and they will. And in most cases, it could be very detrimental to health. For example, in stroke, you're losing 1.9 million neurons a minute.
Yeah,
in a stroke event.
Yeah,
and
you got a half-hour drive to the tertiary center,
right, or more,
or a 3-hour drive,
right? In which case, you've blown 4, 5, 6 million neurons.
Yeah,
messing with that.
Yes,
and
exactly.
It could kill you. Or it could be the difference between you showing back up in that community productive versus needing full assistance and non-productive in the workforce, which is we don't need that today.
No.
But word spreads, and then to your point, what happens is they start to self-out-migrate or self-select, and that's when they get into bypassing the hospital altogether. So in this case, we've seen scenarios where their ED volumes might pick up 15, 20, even 30%. Based on the grassroots campaign to avoid these transfers, simply by putting in solutions that mitigate transfers will pick up additional volume you're missing that you weren't going to get before. And so you not only are starting to retain transfers, but you're retaining volume that was going to drive around you to begin with.
Exactly.
And so that's why it's one of the cornerstones, I think, in a key analysis with hospitals, particularly hospitals that are struggling with census or margins or just patient days in general. And a word of caution to those that are just gravitate to the notion that, Shane, everything's moving outpatient today. I mean, that's why we have nobody in our hospital. There is truth to that. Don't get me wrong.
Right.
But again, and I want to emphasize, there's thousands and thousands of people transferred every day that don't need to be transferred. But it gives you an opportunity to increase, ED volumes, patient days. And in many cases, a lot of this can be mitigated with a lot of services that we offer. And it really gives the hospital a great chance to increase the volumes again, as Chuck and Clinda have doubled them across every single sector, because ancillaries pick up. Heck, in Missouri case, the gift shop volume was up like 500%. The gift shop volume.
That's a good measure. Right,
and again, the only way that volume comes up in the gift shop, or you're selling more coffee, is what? You got to have people in the door. No people in the door, expecting volumes to go, is just not going to happen.
Nope.
So let's talk about what are we looking at when we start talking transfer. As I mentioned before, a lot of times the analysis is very superficial, and it's very sort of, I call it pencil whipping a transfer analysis. And I just try to refocus them on the importance of this. And we really do need to get more granular into the analysis. And so as we go through that, what we've worked with some of the hospitals on is, and again, I can go through the template with them and help them build the template out and even analyze it, which we've done that as well. And by the way, you can get a report out of an EMR in some cases. In some cases, you can customize that report. But it is necessary to elicit the information I'll cover here in just a second. In my opinion, that's most helpful. And so, and I would run this for several years if you can. So the more you can get, the better. But generally, I would like to run it at least 24 months ahead of time or previous. In retrospect, and ideally 36, 48, somewhere in there, if you can,
to really capture
a trend. And I can't emphasize enough, if your trend is maintaining or escalating, it's a major issue. It's a major issue, and you're hemorrhaging dollars down the road on this, which we can't afford in our rural markets.
No.
And so the question is, how do you get more granular in asking why? Well, why is this happening? Versus, I got a report, here's 25 transfers. I go to, that one had to go because of that. That one had to go because of why. So start asking questions like, what do we need to have in place so that we could have kept that patient? To tell me, what do we need? What are we lacking? If you're talking to a provider, for example. But beyond that, in terms of a report, the things that we like to look at is who is the ED provider on, and what were their credentials? Was it an ED physician? Was it an ED APP or a PA? Is it a locums? Because there's factors there. There's influences there.
Factors there.
And then part of the discussion I'll have with the administration is what's the structure of the ED? Are they locums? Are they employed? Who's doing the admission in the event the patient does need to be admitted? Who's doing the paperwork on that? Who's doing the H&P? Who's writing in the orders, et cetera? Who's doing the med reconciliation on that admission?
Yep.
Who the attending provider would be, which kind of coincides with that. But I'm interested to know and have them track who would have been the attending provider for patient X
had they been admitted.
Yep. Because in most cases, if it's a separate provider or separate provider group, the ED provider is calling that individual to then facilitate the admission. And so we need to know who's involved in that process. And so, for example, what we've learned in many instances is, okay, now Shane, I have this question for you. I noticed that my other providers are transferring out, 15%, 20% of their patients. You're transferring out 60%. Why is that?
Why is that?
Tell me why.
Yeah.
Well, my patients are just sicker than theirs. Okay. Well, let's look into that.
Yeah.
But I mean, these are the types of conversations that starts to flourish. Who was the ED nurse? So I'm interested in who the ED nurse was. And I get a lot of questions around all these different topics or corridors, but the ED nurse might, Shane, why do you need to evaluate that? And I said, it's crazy how an ED nurse can influence a family or patient's decision on transfer, because technically the patient should have a say in this process, right?
Correct.
And so, for example, if the ED nurse says, I don't know why I'd stay here, Andy. I mean, I'd recommend transferring to X because
you'll get better care.
You're going to get better care,
higher level of care.
Higher level, and blah blah blah. And you'd be shocked at what you can turn up based on trends with specific individuals involved. It's not going to turn them up all the time, but there are these spots that you can start to find. But you're only going to find them if you look for them, right?
Right.
They're not going to come up and tell you, hey, by the way, Nurse Shane down in the ED last night really told me I needed to get transferred the heck out of here.
Yep.
So, who the primary nurse would have been on the floor or in the ICU, if you're a little bit larger hospital with an ICU. By the way, this is applicable in PPS hospitals, critical access hospitals.
Yep.
From any size, frankly, that is concerned about transfers. But who the primary nurse would have been. And this is a big one because we've actually correlated transfer threshold to nursing knowledge and experience on the floors. And so the lower the nursing competency, experience, et cetera, on the floor at a particular time will impact transfer volume threshold. So,
and in our post-COVID world, that's a real factor.
Oh, for sure. In fact, this was the main catalyst for us developing the virtual nursing program to support this, because this is a classic area that if we determine that because one of the things you'll start to learn as you engage the medical staff on this is one common response is, well, I would have admitted the patient, but Nurse Shane said he was just too uncomfortable with this, and it's a risk, and I've never seen this before, and I'm too busy. I got this, and this going on. And so as you do the analysis and you come up with, well, gosh, on 50% of our transfers, Shane's involved would have been the primary nurse. And so then again, you can start to identify these things. What was the time of transfer? So the time of day, was it at night, day, morning, evening, et cetera? That's important. Weekends, holidays, pretty straightforward. The other thing, and I should go back to this during the providers, but if there is a call system or structure within your medical staff, and on the primary, so who the attending provider would have been, and then who would have been the provider on day 2 or 3. And what I mean by that is, let's say Andy's the admitting provider today, but I'm Andy's partner. So Shane's his partner. and it's Thursday.
It's Thursday about 7:00.
7:00, and
Yep.
Andy gets the call. Hey, I have this patient in the ED, Andy. It's blah, blah, blah. It's got an underlying pneumonia. It's got this. SATs are kind of marginal, but I think, ride a little BiPAP will be fine overnight.
Yep.
I think we'll be fine. And, you say, yeah, you know what? You better, I'd be fine admitting that patient, but I got to turn everything over to Shane on Friday, and he's not going to want to deal with this. Yeah. That's just, this is over his head. It's out of his league. It's whatever. And so it's shocking, the stuff that'll start to emerge as these discussions evolve. But so the patient ends up being transferred. So it is helpful to know who's going to be the subsequent. And again, if it happens enough, because another dissatisfier is admitting the patient and then transferring them out on a routine basis when their condition hasn't changed. And by the way, in terms of the what ifs, it can come back to our experience with retaining these patients and not transferring them. So we're very good at admitting the patients we should be and not admitting the patients we shouldn't be. So it doesn't really do us any good to admit the patient and have to transfer them out 12 hours later. No. So nobody wants that. No. And so it's important to get it right out of the gate. So it's important to have a collaborative team and experience to do that. So the good news is our inpatient transfers are extremely low, less than a couple of percent. It's very low. So it's important to understand who's going to be the handoff in that situation. And then again, back to weekends, holidays, oftentimes we see increased transfers at night, especially heading into the weekend. Holidays is another major one in terms of transfers that tend to go up. And then I would also profile by diagnosis. And so what was their diagnosis in the ED upon discharge or upon transfer? What was the category? And then you can even get a little bit more granular around that diagnosis in terms of, if it was a stroke neuro thing, was it a hemorrhagic stroke? If it was, we would have transferred them anyway.
Right.
But I'll just stop it since neurology and stroke is kind of our first area of analysis. It's a very common one because right now we're keeping 70 to 73% of all stroke neuro patients even in the critical access hospitals, even post TPA. And the only way you can do that is to have a program that meets them at the front door in the ER, treats them in the ER, follows them to the inpatient unit, rounds on them, is available around the clock for calls, questions for the attending or the nursing staff. And so that's a classic example of ensuring that your solution aligns with your problem or what you're trying to solve for. So if you're trying to put in a stroke program to achieve accreditation, certification, or maybe you want to be a certified stroke center for whatever reason, that a stroke program or a stroke service could help do that. But that's only going to help you achieve your certification.
Right.
If you actually want to make a financial gain on this program, beyond offering them some acute insight on TPA delineation, you really need to have the program that can meet them at the front door and then follow them.
All
throughout the stay. And meet the nurse's needs, meet the attending provider's needs, so then round on them just to again, because you got to close the loop on that longitudinal stay in the acute setting. Otherwise, they're just not going to be comfortable enough to keep them. They're going to have to transfer them. So,
and not all stroke programs are interested in keeping those patients local.
No. Well, no. I'm not going to get into the downstream or the underlying motivation of a certain organization put in a stroke program into a hospital. But you're absolutely right. You need to.
But when you're thinking about transfers and ROI, that's a big deal.
Oh, it is. Well, and I encourage all CEOs and executive suites to think about all of their programs. You got to have an ROI mindset with the program. And it can't, especially with stroke and neuro, because stroke and neuro is kind of a feel good one, right?
It is.
Well, again, the 1.9 million neurons a minute, and it's it resonates with people. I mean, the American Heart Association has really been out there with NIH scales and stuff like that, early detection. And it's a good sort of a sexy marketing piece where the hospital can go out and say, hey, we're doing our stroke program. But really, you need to look at it, in my opinion anyway, from can we really build a program that actually keeps people here so we can actually become our certified stroke center and actually take care of more people here than we're doing now. And at the end, actually make a few dollars at it.
Yeah. And take care of them faster. And it's a win all around.
And by the way, I kind of say that's what your patients want you to do. That's what they want. They don't want to drip and ship. You've only solved half of their problem.
Right.
And don't get me wrong, it's an important one, right? To get the med on board, yes. and no doubt about it. But you're missing a key 50% of the piece of the puzzle, which is to keep them there.
Yeah.
And the only way we're going to do that is to have a program that meets that need.
Exactly.
Otherwise, you're going to have a misalignment in the program versus your ROI strategy. Now, if you don't want to include an ROI value proposition as part of that program, well, then it's irrelevant, I guess. But something I would consider. Other categories: cardiology, pulmonary, critical care, medicine, ID or infectious disease, trauma, nephrology, and really the list goes on. But really a comprehensive list of diagnoses and what are you seeing going out the door, and how can we develop programs around that?
Yeah,
in order to save the hospital time, money, effort, energy, keep those patients right in the door. And it's really it's a helpful tool to sort of start categorizing all of those things. But really, it is as a whole, in my opinion, one of the most important things that the executive team should be reviewing on a monthly basis. And it depends on the size of your facility. And I've met some executives that are all over this, that are very tuned into this. Maybe not quite to this level of detail, but. And but these are where the conversations get fun with the executives, because, well, now why would I want to know that? Well, here's what we've seen. Yeah. And well, gosh, I didn't even think of that. Well, that's why, because oftentimes this gets back to a conversation with the medical staff, which are often fragile in these situations. And how do you go to a physician and say, hey, gosh, Andy, you've been transferring out an inordinately high amount of patients for the last 3 years. Here's the data. Here's how it compares. And oh, by the way, our facilities admission percentage is at 4.5%. We need to be 8, 10, 12, 14, whatever. So we're way below where we could be there. Our numbers are inching up again on our transfers. Help me understand why. What's your hesitation to admit patients here, and just open it up for conversation and try to flush out the underlying root cause of that. And depending on those conversations, there's definitely solutions that we could deploy that help mitigate that.
Yeah.
And man, there's some dicey conversations. I've been involved in a lot of them.
Yeah.
And they're all fun. But in the end, if we keep the patient front and center and the hospital's success and sustainability front and center, these conversations have to happen. They
do. Yep.
And again, I go back to I was speaking at this conference in Nashville, and the question that was asked to me was, what's the most provocative, controversial thing the most controversial truth that you've learned in the last 12 years of doing this? And I thought about it for a minute. And I said, I would say the number one thing that I've come across is the CEOs. I kind of explained that your hospital's a jetliner, and the CEO is the pilot.
Yep.
And it's on the nose is pointed down. It's on a downward trajectory. Maybe it's not a nosedive. It's just a gradual descent right into the ground.
Yeah.
And the CEO knows that they need to pull the handle up, but their hands are handcuffed behind the seat by the medical staff.
Yeah.
And it was funny. I was talking with the CEO the other day. He goes, I've been on that plane. I've been on that plane. But between the med staff was just a major challenge. But so we have to find a way to overcome that. But I've had CEOs literally walk out of the office and go, saying, we got to do this. We should do this, but there's no way I'm going to get this over the hump. The medical staff's just not going to go for it. And listen, you and I both know you're transferring all kinds of people who don't need to go.
Yep.
So you're going to have to find a way to engage these guys. And it's a tough spot, right? Because in some cases, most cases, they have a lot of power. And in some cases, they have a lot of board influence. Some cases, they sit on the board.
Yep.
So some cases it gets down to, it could cost you your job almost, or that to that level. So, I mean, it is a very fragile situation. I'm not trying to suggest it's not.
No.
But the reality is we have to try and find ways to paint the picture.
Yeah.
That listen, we're gonna close.
Well, yeah.
or
and find those objections and find ways to overcome them.
Yeah. And there's ways. We've been down this road so many times over the years in helping hospitals and executives and C-suites and boards approach medical staffs on these fronts. It's a major, it's a tall order, but it's an important one, and we're here to help with that journey. In some cases, it's helpful to hear it from an outside entity. Other cases, not so much.
Not so much.
It just kind of depends.
Well, and it varies from facility to facility. Some the docs are employed, some they're a third party, some they're locums.
Oh, for sure.
It's just a mix of different situations.
It is. It's a large mix, and the bottom line is, I encourage them all to have those conversations. And this transfer analysis report gives you starts to acquire some very granular data and some information that you can start conversations with them at a higher level. Versus, hey, why'd you transfer Shane out yesterday? Well, because he needed to be. It was a safer thing. It was the quality of this. Or that Nurse Rick didn't want to deal with it or wasn't comfortable with it or whatever.
Yeah.
So it can start you to drill down on that. I would recommend, once you have the report and you sort of honed it and massaged it into the position that you want it to be in, I would recommend the report is on a appropriately scheduled basis with the senior management team. So senior management's reviewing this transfer analysis on a weekly, monthly basis, quarterly basis, whatever, depending on your volumes, right? And I would put that much emphasis on it. It's that important.
It is.
And furthermore, it's a big deal for physicians to know you're looking at this and you're looking at it in a very granular way. So I would be very transparent with the med staff on how you're going about this and why you're looking at this. And I wouldn't call anybody out, but it'd just be, here's the thing. Here are the things we're looking at. Here's why we're looking at it. Here's the data. And so sometimes it'll make a difference just them knowing you're looking and you're watching.
Yep.
I would review this in the same, not in the same cadence, but once a quarter or thereabouts with the medical staff. So the medical staff knows coming in quarter X is going to be our first transfer analysis report in front of the med staff. And so we'll have a discussion, It's just those types of things that, again, you're not calling anybody out. The data will call them out.
Yeah.
You don't have to. The data will do it for you. So that's an option that I recommend. And then the other is with the board. And this is another interesting concept. I think that I've always been a huge advocate of involving the board. Not in operations. I'm not, again, their CEO's going, Shane, shut up. What are you talking about? Why would you bring I don't need the board to get any more micromanaging than you already are. But really, it's more of an informative thing. Just say, hey, listen, we're evaluating transfers and here's why. And that way, if they're getting some unilateral conversations from the med staff heading into the board, the board members are positioned to respond to that. Say, here's why as an organization, we're looking at that.
Yep, exactly.
And why the board feels it's important that we look at this too. So I think it's good. And again, I recommend reviewing all virtual care and digital health strategies with the board on an ongoing basis. So they're in the know of what's going on with your solutions and how they're impacting your facility and ultimately your community. So,
yeah.
But so no, I think the transfers again are just a key piece. And so I think it was a relevant topic for our podcast.
Absolutely.
And it was requested. It was a requested topic. And I would say of the engagement sessions, it's one of the more popular landing spots that we spend some time on is just talking about transfers.
There's a lot to dig into there.
Yeah,
so
for sure.
Cool. Well, it's been great talking about transfers today. I think it's been good information.
Well, hopefully it will help somebody out there.
Yep.
And if somebody has any questions on that, feel free to reach out.
Yeah.
And happy to do either an engagement session with them or as far as if they just want the transfer analysis information, we can get that to them as well.
Okay.
But we have a detailed metrics sheet that they can go. I won't go through that on the podcast, but that it gives them a little more detail around the stuff we just talked about.
Cool. All right. Sounds good.
Perfect. Well, if anything else comes up with our clients out there, I just want to shout out to all of our rural health providers. It's a challenging time out there.
It is.
And keep up the fight.
Yeah.
and just know we're here for you. And if you ever have any questions, any question for that matter, of, hey, do you have an idea of a solution that might be able to help us on this front?
Yep.
By all means, reach out. And you know what? We have a lot of partners too that are just side strategic partners that we may not provide a certain service, but we know somebody that does. And so feel free to reach out to us on any fronts that you find is an issue or challenge that you're facing, that you're struggling to solve, and maybe we can help.
Yeah. Sounds good.
Awesome. Well, thanks, Andy. I think this was a good one. We would like to thank you for joining us today. Our promise to you, the listener, you will be inspired or at a minimum find value in the information shared in this podcast. Please offer a comment or offer feedback so that we can improve this podcast and better meet your needs. Please remember to share this podcast with others that you feel may get value out of this by listening. And it's always helpful to subscribe to the podcast channel so that you're aware of future episodes and releases. In addition, if there is a rural health topic you would like to have covered on this podcast, please leave us a comment, or you can send an email to pulse@teledynehealth.com. That's pulse@TELEDIGMhealth.com. For more information or general inquiries, please visit teledynehealth.com.